go. All right. Okay, well, good morning, everyone. Welcome. It's lovely to see you. Beautiful day. I have my PowerPoint in presentation mode, and I haven't done that in the past, so we'll see if that works, and just forgive me if we have technical issues or user error, which is more likely. All right, so it's our May meeting, and I can't quite believe that's the case. There we go. The year is just screaming by, but here is what our agenda looks like this morning. And so we'll go ahead and move into our welcome and introductions. So I think what I will do is just look at the participants on my Zoom bar, and we'll go through and I'll call you out by name, and hopefully you're able to either unmute and tell us who you are and the organization you're with, or put it in the chat, which we've found is a really useful tool in these meetings. We like the chat on Zoom a lot. So I am Mindy Tueller, and I manage the Medical Home Portal, and I manage the Utah Children's Care Coordination Network. And I think most of you know me. So let's see. Actually, Haley, I think I see you next in the list. So if you wanna go ahead and introduce yourself.
Hi, I'm Haley Mclaughlin. I'm just the nurse in adolescent medicine and the GEMS clinic, and the clinic coordinator for those clinics. And that's all I got, unless you need me to tell you more.
Oh, that's great. Thank you. We're so happy you're here. Next on my list is Amalia. Amalia, are you able to tell us? You may not be able to. Looks like you're muted. You know, Amalia is part of the UPIC, and
yeah, she's our newest care project coordinator, and she works with Dr. Paul Carbone on the Aspire program, a project, and also helps at UPIC.
Excellent. All right, thanks, Gabby. And Gabby, while you're talking, why don't you just introduce yourself?
Yeah, so my name is Gabby Baragoshi, and I am one of the QI coaches at UPIC, and I believe I know several of you and have worked with you in the past.
Excellent. Thanks, Gabby. All right, Athena, you're up.
Hi, I'm Athena Parker. I'm with the Medical Home Portal and help maintain the Utah Services Directory, and then work with some of our state partners as well.
Terrific. And Cassie? Cassie may not be able to unmute. I'm seeing some chats. Let me pop in the chat box. Cassie, she's Cassie Crane, and she's a care coordinator for Wasatch Pediatric South Point. We're so glad you're with us. And Amalia says her connection signed her out, and she's a project coordinator with Pediatrics at the U of U. Yeah, excellent. Okay. All right. Oops. Didn't mean to switch screens. There we go. All right, Dora, you're up.
Hi, good morning. I'm Dora from Shriners Hospitals for Children. I'm the Professional Relations Coordinator.
Glad to see you this morning. And Gina, Money.
Hi, Gina Money, Family Advocate.
Good morning, Gina. Glad you're here. All right, and our other Gina, if you don't mind, Gina from UV Peds.
So Gina is the care coordinator at Utah Valley Peds at American Fork.
Right, great. All right. Ileana.
Hello, this is Ileana from Southwest Children's Clinic, and I'm the manager at Southwest Children's Clinic. And I have Janet. Okay, I'll wake up. I have Janet, which is my wonderful care coordinator that does a fabulous job. I got to make that one up, but good morning to everybody.
Good morning. All right. Yeah, it's hard. It's Wednesday. We're getting there though, guys. The week we're on the downhill slide. All right. Good morning, Janet and Ileana and Janelle.
Good morning. I am the nurse care manager for, I have a few clinics within Intermountain, Holiday, North and South, and Altaview. I have a few doctors there as well.
Great. We're so glad you're with us. All right, Katie. Katie, vote.
Hi, I'm Katie, and I am one of the care coordinators at the University Pediatric Clinic up at the main hospital.
Great to see you.
You too, thank you.
And Kelsey. I think it's Kelsey Hamadou.
Hi, I'm Kelsey. I am a care coordinator at San Juan County Health Department with Integrated Services Program.
Glad you're here, Kelsey. And Melissa Higley.
Hi, I'm a care manager at Altaview Pediatrics.
Great, welcome. All right, and Michelle Redfield.
Hi, I'm Michelle Redfield. I'm the administrative assistant for UCCCN, Medical Home Portal, and a few other groups.
Right, glad you're here, thanks.
Thank you.
And I see someone who has MKACHERR, so something maybe cherry at the end. If you're able to tell us. Oh, Amy Cherry. Okay, great. Care guide at Northern Utah Pediatrics. Welcome, Amy. We're happy you're here. That's great. Okay. All right, Natalie Allen, you already put your information in the chat, so I'll just read that. Nurse practitioner for the Department of Health ISP team, and you don't have a mic today. Well, we're always happy that you're on, Natalie, and we'll watch for anything that you put in the chat. Linda Stevenson.
Hi, I'm Linda from the ISP team in Central Utah.
Glad you're with us this morning. And hey, Sharon, how are you? Sharon Norda.
Hi, Sharon. I'm the nurse care coordinator with Rainbow Kids up at Primary Children's Hospital.
It's great to see you. All right, and Sherilyn.
I'm Sherilyn. I'm the nurse care manager at Intermountain Pediatrics in American Fork.
Great. So glad you guys are all here with us this morning. Wonderful. And Tiffany.
I'm Tiffany with Utah Valley Pediatrics at Timpanogos.
Very good. Welcome. All right. And I know Tony Estrada put her information in the chat, care coordinator with Integrated Services Program. Good morning, Tony. All right, and Walt, do you want to unmute, Walt, and tell us?
Yes. Good morning. This is Walt Torres with Integrated Services Program. We're part of the State Health Department, and I'm a care coordinator, and I'm located in the Salt Lake office.
Excellent. Good morning and welcome, Walt. All right, I see somebody who has a University of Utah ID who's signed in, U050. Does that sound familiar? And are you able to tell us who you are? Not sure who that is, so that's all right. And then Yvette, I'm so glad that you're able to join us today. And I'm so sorry for all the trouble getting you invited to this meeting. We'd love to have you introduce yourself.
No, you're okay. My name is Yvette. I'm one of the patient care coordinators here at the General Pediatrics Clinic with the University of Utah.
Well, we're delighted you're here. Wonderful. And Eric, good morning, Eric.
Good morning. I'm Eric Christensen. I'm the program manager for the Integrated Services Program with the Utah Department of Health, Bureau of Children with Special Healthcare Needs.
Good morning and welcome. And someone named Allison, just Allison.
Sorry, I don't know where my sound's coming from, but I am a care manager with Hillcrest Pediatrics.
Excellent. Good morning. And I think we're going to wrap it up after this, but Gwen, I see Gwen has joined.
Hi, I'm Gwen. I cover Southeast Utah Health Department area, Grand, Carbon, and Emery counties. I work with Eric's team at Integrated Services.
Good morning and welcome. We're so glad that you are with us this morning. Wonderful. All right. So we've done our welcome and introductions, and now we can go ahead and do some announcements. We've always let you know that we encourage you to try and join our meetings via computer or some device that would allow you to use the chat feature if you want, so that you can see us when we can see you. But of course, we're just glad that you're here in any way. And we will end promptly at 10 a.m. this morning and give you, back any time that we can. So an announcement, we just wanted to remind you again about the Spark Autism study. We talked about this at our last meeting and had Dr. Paul Carbone, who is the PI for the Utah component of that, talk with us a little bit about it. But I wanted to let you know that if you are willing and able, they would very much like you to have materials to hand out in your clinics and to be able to hand out or talk about with your families. So this is one, there's actually two parts of this. I'll show you the second. This is one that we can make sure that is available to you if you'd like to have that in a handout, and also certainly can make it available to you digitally. So Allie Andrus is the point of contact at the UDAC Spark program, and she would be delighted to hear from you about your interest in having some of these materials to hand out. We know it's a little bit tough because what happens with the Spark program is that there isn't really necessarily a loop to let you know that the family you've referred has joined the study. It would only be if they let you know that they had been participating. So it feels like maybe a little bit of a black hole, but it's really such an important thing, and we hope that you'll stay aware of it and try and communicate that to your the patients for whom it's relevant. They do get an Amazon gift card for participating, and they don't have to do anything beyond just being in their home, going online, and then getting the materials in the mail. So it's very simple. And it's really interesting. It's really one of the largest studies on autism ever. And the University of Utah is a member of that very large study. So we hope that you'll be interested and willing, and I'll make sure to send out this information after the meeting. And you can always get in touch with us with any questions. All right, so we are going to talk a little bit about a new category of service providers in our services directory. Athena, I'll kind of toss the time over to you if you don't mind. She's ready. Here we go.
I have to unmute though for you to hear me. So I just wanted to take a little bit of time to spotlight a new category that we have available in our Utah Services Directory. If you're looking for COVID testing or COVID related services, there's now a category for that. And if you go to service category and just type in the word COVID, it will pop up here. It's called COVID-19 and related testing. And you can see here that we have a handful of service providers that have indicated that they're offering specific either diagnostic testing and or vaccine access. And they're listed here. There's also a couple of one specific or statewide services down toward the bottom of this list, the Test Utah COVID-19 and then the Utah coronavirus information from the Department of Health are listed there as well. If you know of other services that you'd like to see here in the directory, again, we always encourage you to use this suggest new provider button at the top, where you can enter in information and then it'll be included in the directory. One other thing that I wanted to bring up is we're exploring the idea of making our lists a little bit more user-friendly within electronic health records. So I want to use an example of the list I created last month for this meeting, the April UCCCN Resources of the Month list. So currently, if I want to share this list, I can get a URL. But as you can see, this URL is a little bit complicated. So if I stuck this in, for example, in an after visit summary or patient handout, it would be a little bit complicated for them to retype and get accurate. So we're thinking about the idea of generating QR codes for patient lists as well, or these kinds of the specific provider lists on the medical home portal, and just wanted to take a minute to get a little bit of feedback from all of you about what that would look like and how that could work within patient summaries. So if anyone has any input on that, please, you can pop in the chat now or unmute yourself. I would also, while you're thinking about that, love to hear how you are currently using lists within your clinical practice. Are you cutting in, are you using the URLs that are being provided? Are they going into patient summaries? Are they mostly getting emailed? Like how is that working?
So I'll just jump in for a second, Athena, as people are thinking. So I'm the mom of a couple of kids in the university health system, and we use my chart, and I use my chart a lot. So I'm just kind of thinking, if I were being told about some providers that they should seek out and go see, if I were to be in my chart and I saw a link like that, but I couldn't click on it, or they printed it for me at the end of the visit, I don't think I would try, but if I had a QR code, and so for instance, I'm not sure if it would work like this, I would want to try it out, but if I have the app on my phone, and if I were to open my chart on my phone and there was a QR code for me that I could click on, and my smartphone's QR code reader would just take that and open it into the list. And then I could click on the service provider link inside the list, and it would take me to, information like you can see kind of right in the grayed out area, an address and a phone number and more. I think as a parent, I would be much more able to utilize that, where I might just disregard if it was just a printed long URL. So that's kind of how I've been thinking about it.
Yeah, any other thoughts on that? We'd love to hear input, especially from those that are in clinical practices, putting together patient summaries.
Hey, Athena, this is Tony.
Yeah.
Typically what I do when I make a list is either copy and paste and email it to the parents, or make the list and email the whole list to them.
Okay, so not even using the link.
No.
Okay. There are a lot of care coordinators on this call, everyone. What are you doing?
I just glanced at the time, and I will say that maybe we can plant these seeds, and I think we'll carve out a little bit of time in our June meeting to talk about this more. So if you want to be thinking, and we'll probably, reach out to you in between to have you think about it, maybe even show you what it would look like between now and then. But yeah, we're wanting to see, how we can make this more valuable. But I'd also like to make sure we do a little brainstorming this morning and do any case updates or cases that you need help with. So thank you, Athena, very much.
And I plant just one more question for people to think about for June. Especially think about how we could better integrate what you're doing with an electronic health record in terms of maintaining lists within the portal. So there could be more crossover between those. We'd love to hear more about how that could be more user-friendly.
Great. Thanks, Athena. All right, let's see if I can get back to the PowerPoint. All right, so we talked about the new COVID-19 service category, and we talked about wanting your input regarding after visit summaries and lists from the portal. And I did want to let you know we have a couple of new pages of clinical content. So sensory processing integration disorder is brand new. And then as kind of part of our sleep issues set of pages, sleep disorders and parasomnias. And we'd love you to check those out. Okay, so now I just want to let you know that if you have any resources, difficult cases, case updates, ideas, concerns, thoughts, this is a great time to bring them up and have a little crowdsourcing from this great group. You're welcome just to unmute and start talking, or you can put it in the chat.
This is Dora from Shriners Hospital. I was just wanting to give a little reminder that Shriners does treat common leg, foot issues like in-toeing, flat feet, knock knees, bow-legged, toe walking, anything like that. And a lot of these do resolve over time. But if you have any patients that you have concerns over, they do treat them at Shriners, and we have an in-house orthopedic department. So that if they need anything, they do collaborate with our surgeons and they build them in-house for them, braces or even anything with flat feet, they build inserts. So just a little reminder.
Thanks, Dora. And Gwen put in the chat that she has an update. So we'd love to hear that, Gwen.
So thank you guys. It is so nice to have such a vast resource of people. So this is my little kiddo that has severe epilepsy and he has seizures. He has to wear a helmet and his little helmet is dented. And dad lost his job. Mom works for Smith's night, and his rescue meds at school expired. So then when he needed rescue meds at school, they can't give them to him because they were expired and they had no money to get new, and they were losing their home, and the home is up for sale and they're going to live in a camp trailer, and this little guy would not be able to live in the camp trailer with them. And you guys all referred me to DSPD. And so Mindy Olson helped, and they have a whole team, and he has been approved to be able to go to a facility. He did get approved for Medicaid. So now he has Medicaid on his own, and they are in the process of finding a facility, and they're actually hoping, they were looking at most of them are up in like Utah County or north from us, but they are hoping that maybe they can find a chrysalis home in Price. So family would still, be able to see him more regularly. We're not sure on that, what his needs assessment's going to say, but he has been approved. And this poor little mom, when you just see her face, and you guys know this because you work with moms like this too, but you could just see in their face the relief and the appreciation. And so it's really nice to have a whole team of experts to help us. So hopefully this little guy will be going into a home in the next couple weeks, and he will be more comfortable, and mom will be able to relax knowing that, his needs are being met. So thanks, everyone.
Gwen, that's good news. That's really good news. Thank you for the update. I still wish that circumstances were different, but I think that sounds like it's heading in the right direction. And I'm so glad that, you were able to connect with the right people and have the help of this group.
I appreciate this group very much. So thank you. And the mom does too. Like, I think, it's unfortunate that she didn't know that these resources were out here until it was, almost, too late for her, but they didn't qualify for any personal care or anything. So I think she appreciates knowing, because I'll say, well, I'm meeting with this group and they'll help. And she appreciates it too.
Wonderful. Wonderful. All right. Anyone else? Any opportunities for motivational interviewing or doing any quality improvement? And anyone else who'd like to mention any updates on previous cases we've heard?
I didn't want to throw Pat Rowe under the bus, but I wanted to ask her a question. I remember at some point in the last month or 6 weeks, she had some funky complex case, if I remember correctly, that she put through to everybody for some help. And I just wondered if anything had turned out well with that one.
Let's see, I'm not sure if Pat is able to respond. Looks like she's muted. Pat, if you're able to answer that, or maybe in the chat.
There we go. Does that better?
Yes.
Yay! Sorry. Okay, Eric, tell me again. I've been thrown under the bus so many times now. I peel the tire tracks off. I'm good.
You know, once you're a speed bump, always a speed bump. I was just wondering, you had mentioned, and I don't have the particulars, I just remember you put kind of through a case to the whole group, I want to say within the last month or 6 weeks, about it sounded like a semi-complex kid you were working with. And I didn't know if you remember who that was, first of all, and if you had some resolution for that. Because I know you do work with some complex kids.
I am so sorry. I don't remember which one. And thank you. I do see a lot of complex. I really can't remember anything specific. I will share, though, big shout out to the care managers, to Jade and Susie and another one of their colleagues up at Healthy U. We recently worked together on a 19-year-old young man severely delayed with complex issues who left the hospital AMA. And because he was over the age of 18 and had some real medical issues, we were able to work together and transition him to his Medicaid benefits, because so much of what we were doing here with his commercial insurance didn't cover the nursing care that was required at home. And so just a big shout out to them, because I think they did a great job in a very difficult situation.
That's good news. I love hearing the stories of us all working together. That's what it's all about.
Before Eric mentioned the case, and Eric, if I can remember it all, I'll send you an update for sure. But one of the things I'm working with here at Select Health is we're having trouble with some of the coding that gets submitted for autism testing, you know, the stat part of that testing. And it's getting denied. And I'm now working with a coder within Intermountain Healthcare who's helping us. So I'm hoping that will be it'll have a great outcome where we'll be able to help cover that particular test code for these kids that are getting screened for autism before they have to move forward getting an actual confirmation. So that's just something I'm working on currently.
That's fantastic. You're a powerhouse, Pat.
Thank you.
Hey, Pat, this is Eric again. It's highly likely, too, that I invented something. I sometimes live in a parallel reality. So it may very well not have been you who put through a complex case. For some reason, I thought it was. So
no.
At any rate.
Donna from Southwest Children's Clinic, and I don't want to throw Pat under the bus. I want to say thank you very much. I think that the biggest frustration for some of our providers is having a child that has needs and not having the resources or know who to go to. They feel a lot of frustration because the last conversation I had with the providers, like they feel like there's a lot of mandates of things that they should do, where to send people and stay within a health plan. And yet then when they do have a complicated one, they don't even know where to start. And I did reach out to Pat, and I want to say thank you very much. She gave me resources of care managers that we can connect to help. And it's this young girl that we're still working with her, but you know, she's 8 years old and she's 197 pounds and having a lot of home issues and has a lot of issues. And we needed help and resources to just get her to the right place and the provider feel comfortable that she was taken care of. And so I really appreciate Pat giving me some resources and being able to reach out to care coordinators to help our providers, because I think with this one kiddo, I think I spent over an hour on the phone just trying to find out, you know, where I could send her and get help and help the provider. And the provider's telling me, Ileana, I don't have the time to do that, but yet I'm so worried for this patient. And I really appreciate this group because that's where I get my resources. So thank you, everybody.
Oh man, I love hearing that too. And I'll just take one moment before we move into our main presentation to remind you that we have our listserv, and we really encourage you to use that in between meetings. It's for you, and it's to, you know, make these connections and get the help that you need. You don't have to wait until our monthly meeting. We can help one another anytime. And I just absolutely love how willing everybody is. When we send out one of those emails, everybody just joins in with suggestions and help. It's terrific. So.
Hey, Mindy, it's Heidi. Can I just ask one question?
Sure.
Okay, I'll be really quick. And I'll send it in a listserv. So I am working with the Utah Department of Health I'm on the asthma task force for them. And we're trying to, one of the epidemiologists is writing hopefully writing a chronic disease reporting rule for asthma. And so I need to send, and I need to figure it out, but I need to know, maybe Pat and Jade could help me if any of these codes are billable and payable. One, and then two, if I could send this in a listserv to see how many of these codes the clinics use when they see an asthma patient. So
okay.
Just so you know, that's coming this week.
Heads up. Okay,
Yeah.
sounds good.
Heidi, feel free to send those to me and I'll check them out for you.
Great, Pat, or I'll just run them down the street to you.
Yes, it'd be good to see you. We live on the same street.
I know.
We never see each other.
I know. Oh, thanks, Pat.
All right. Thanks, everyone, so much. I think we'll go ahead and move into our next section of the meeting.
And this is Chuck. I'm pleased to introduce Dr. Andy Pavia, who I think of as Utah's Dr. Fauci. You know, they're both New Yorkers, they're brilliant, athletic, and the go-to experts for news organizations, most recently for Andy and a front page story in Monday's Salt Lake Tribune. His background includes as an internal medicine and pediatric residency, followed by serving as an epidemic intelligence officer and a preventive medicine resident at the CDC. He completed a fellowship in pediatric and adult infectious diseases here at the University of Utah and joined the Department of Pediatrics in 1991. He's been chief of the Division of Pediatric Infectious Diseases since 2003 and is also director of hospital epidemiology at Primary Children's. He serves on numerous prestigious national organizations and committees related to infectious diseases, particularly influenza. And we're very pleased to have him talk to us about COVID and what concerns you all might have. Take it away, Andy.
And mute there. So you tempt me to do my Dr. Fauci presentation, but I worked so hard to get rid of the accent. Now, unlike him, we didn't come from the same part of New York either. But anyway, what so Chuck invited me here mainly to answer your questions. I think it's a really important time for pediatricians in the course of this pandemic, because we now have the opportunity to vaccinate kids 12 and up. And you probably heard me say this in other venues, but I think that's incredibly important. Not all kids are the same when it comes to COVID. The older you get in your teenage years, the higher your risk of getting significantly ill, the bigger role you play in transmission. Given our limited data, the more likely you are to have long COVID symptoms. So teenagers really need to be protected from the virus themselves, but they also play this very large role in community transmission. And without having immunity for them, we're really not going to be able to control community transmission. That said, I think you've all seen some of the preliminary data. Although it was relatively modest sized clinical trial, efficacy was 100%. That's kind of impressive. The safety profile looked exactly like it does in younger adults, people under 50, that is. There were slightly higher rates of side effects with the second dose than there are in more seasoned people over the age of 50. And so sore arms, very prevalent, fever, malaise, headaches, myalgias in about a third with the second dose, less with the first dose. And the immunogenicity was excellent. It was actually better than it is for other young adults. So, we've got a terrifically effective vaccine. The safety data are very comparable to any other vaccine we have. They're now based on 200 million Americans under observation. No vaccine's completely safe, but this certainly ranks up there as safe vaccines. And the challenge is to figure out ways in which to get our young people vaccinated. And I think part of that's a practical aspect. How do we get vaccine to the places where people want to get vaccinated and where they have the time and the habit of getting vaccinated, which to a large degree is going to be pediatricians' offices, maybe followed by churches and pharmacies. And then the second challenge is, how do we convince people that it's important and that it's safe and that there's a huge benefit? I've said it before and I'll say it again. I think it's pretty easy to convince teenagers that for the sake of getting a shot, you can return to normal life and contribute to helping the community. That's a pretty easy sell. Their parents are sometimes a harder sell. So with that, I think I'll just throw it up in the questions, Chuck, if that's okay with you. You had a few
Sure.
that you suggested in advance. We can with those or questions that people have. And I'm happy to talk about anything, and bore you to death with details about mutations and receptor binding domain among variants. We can talk about what's happening in India, but I do think it's a really important moment to think about keeping kids safe through vaccination.
But would it open it up, and if folks are reluctant, I'll start on my list.
This is Heidi Bates. I am a nurse. I work with UPIC. My question is how they came out to say that we'll probably need a booster. When would, do you know when that information might come out? Is it going to be like a yearly booster? Is it like a flu? When you get the flu shot every year, they're going to give you a booster at that time. Is it every 6 months? Do we know that information?
Yeah, the reason everyone keeps asking the question is we don't really know the answer. We know that from other coronaviruses that immunity is not lifelong, probably in the range of 2 to 3 years. We also know that at 6 to 7 months, there's pretty durable protection as well as durable levels of antibody from the vaccine. And actually the stability of vaccine-induced immunity seems to be quite a bit better than that from mild or moderate infection. But we don't know exactly how long that's going to last. The way we usually do this with most vaccines is we do effectiveness studies in which we look at effectiveness by time from vaccination. It's what we did for understanding that Tdap doesn't last very long. So we're not going to have that answer until at least a year into general vaccination. If you look at the decay of antibody rates, there's a very nice paper just came out yesterday in Nature. It's fairly mathematical. It does a lot of extrapolation from things we're not too sure of, but it suggests that we should have pretty robust protection well beyond 1 year. So what's my best guess? I don't think we're going to be boosting anybody in 2021. I think boosters will be necessary at some point. I would suspect that annual boosters are not going to be strictly necessary, but it may be the most effective way to do boosting, because every other year, every 5th year, how hard it is to keep people up to date on things like tetanus immunization. So if it turns out the protection lasts 18 months or 2 years, it will make more sense to do a yearly booster. It's not a very satisfying answer, Heidi, but that's the best we can do. No boosters in the near future, but probably eventually.
No, that's great information. Thank you very much.
And is it likely they'll be incorporated into an annual flu vaccine?
It would make a lot of sense. I think what everyone's probably heard by now is that we don't need to separate vaccines from the COVID vaccine anymore, which is great. Gives us the opportunity to develop, either plans of co-administering or co-developed vaccines. Whether or not it's put into one vaccine is going to be, I hate to say it, but it's probably going to be a financial decision by the vaccine companies. If they think they could sell more vaccine by making a combined shot, they will develop it, test it for efficacy and safety. But I don't think that's going to be something that NIH is going to push very hard as a necessity.
And how young do we expect approval for vaccines in kids? I mean, do we expect it down to like 6 months level or going forward?
Well, the plan is to develop data down to 6 months. The ongoing studies from Moderna and Pfizer, are doing the sort of typical stepped age groups that you would expect. They're going to do 6 to 11 is now enrolling. Some of you may even have your kids enrolled in that, because a lot of pediatricians' children are the people who lined up first to get into those studies. And if that proves safe and effective, which it probably will, and once they have a sense on the dosing for that age group, they're going to do 2 to 5 and then 6 months to 23 months. I'm not 100% sure that they'll follow all the way through with the 6 to 23 months, because that age group doesn't have the kind of high level exposures, doesn't tend to get terribly ill, although there are always exceptions to that. And, if you spent the winter in primary children, you saw a lot of very sick kids with COVID, contrary to, the rumors that are going around that kids are just fine. And that age group plays less of a role in transmission. Long way of saying, I'm pretty sure we're going to go down to 6 years old so that school age kids can be protected and schools can operate safely. Beyond that, I think it's going to depend on where the pandemic is at the time and how the data look in kids.
Makes sense. And are there data on teenagers with type 1 diabetes and how they responded to the Pfizer vaccine?
So I'm trying to remember the presentation. They excluded kids with serious immunocompromising conditions. And I'd have to look back at the trial to see whether type 1 diabetes was on that list. So no kids with cancer, no kids on rheumatologic biologics were enrolled, but kids with asthma, kids with modest repaired heart disease were enrolled. Type 1 diabetes, I'll have to check and get back to you. What I can tell you is that for adults, diabetes is not associated with a decrease in immunogenicity or in efficacy, unlike some of the immunosuppressive drugs.
Any difference in side effects for that group?
In adults, no. So the adult trials, if you remember all the way back to December when they were being presented, they enrolled specifically people at high risk, people with heart disease, hypertension, diabetes, multiple medical problems, excluding active cancer and high-level immunosuppression. And efficacy and side effects were similar in all subgroups, which is very cool. The biggest predictor of more side effects was being young.
And another question in the chat, why is the shelf life of the vaccine so short? Only 3 weeks, 2 in the freezer, 1 in the fridge. What's different about this vaccine versus others? So one issue is there's no preservative.
But that doesn't account for why it has to be at ultra low temps. And I don't have all the details of the formulation, but when Pfizer first developed the formulation, they tried to minimize the amount of excipients they put in it. And they were concerned, based on some preliminary experiments, that mRNA would degrade at routine freezer temperatures. What we've seen is that they keep expanding the stability data and presenting it to FDA. And so it's up to a month in a regular freezer and 2 weeks in a regular fridge. The European Medicine Agency just approved a month in a regular fridge for the Pfizer vaccine, and the FDA are reviewing the data, and we expect them to approve that. So sometime this month, it'll go from minus 80 fridge for a day, 6 hours after you thaw it, to minus 80 regular freezer for several months and a fridge for 1 month, which is great. But you still have to discard the vial 6 hours after you've reconstituted it. So that's something of a limitation. We have a bit of, we have a lot of vaccine right now, and the state health department is reminding us that unlike December and January, where we're going to squeeze every drop out of every vial, if wasting 2 doses means that 4 people get vaccinated who otherwise wouldn't get vaccinated, that's worth it.
And what advice can our members give families of immunocompromised children regarding return to the community after the vaccination?
That is one of the sticking points here. There are good data in transplant patients that suggest that while many respond, it's not predictable, and the rates of response are relatively low, particularly after 1 dose. So solid organ transplants, only 20% had any immune response after 1 dose, and about 50% after 2. It's not quite so bad if you're, say, on Remicade or another biologic for JIA or Crohn's disease, but immunogenicity is reduced. Probably duration of protection is also reduced. So we think there's a real benefit to vaccinating these kids. It may keep them from getting a disease severe enough to get them hospitalized or end up in the ICU, but they're not fully protected. And it does mean that our immunocompromised kids are going to have to keep masking and avoiding high-risk situations. And I think it's become more difficult with the recent CDC guidance, because it's not the lack of mask use by people who are vaccinated that puts immunocompromised kids at risk, but it's the fact that, as we know, even with the mandate, it was difficult to get people to use masks reliably. What we're seeing now, of course, is that both unvaccinated and vaccinated people are not wearing masks. And so there's a greater risk for an immunocompromised kid, going to a movie theater or to a crowded indoor setting.
And along that line, what are your thoughts on schools not having kids wear masks the last week of this year's session?
I think it's a terrible idea. Did I sugarcoat that enough?
In your usual style.
We've demonstrated that in Utah, we were able to get kids to have in-person learning and do pretty well with it because we had a mask mandate and it was strictly enforced. There's a really nice study some of you may have seen, in elementary schools in Utah, and a similar study done in Georgia. In Utah, where mask wearing was quite good, transmission in the classroom was extremely rare. In only one of about 21 classrooms where there'd been 1 child with infection did anyone else get infected in the classroom. In Georgia, where masks were expected but poorly enforced, and observations showed that kids were not wearing masks very effectively, there was quite a bit of transmission in the classrooms. And there's lots of data like that. So we know that if we want kids to be able to go to in-person school, have a relatively normal life, masking works until we get a lot of the community vaccinated, we get our teenagers and tweens vaccinated, and we get the rates down. And I think going to the end of the school year made tons of sense. Hopefully that means that we'd be able to approach the fall without having the need for masks. But, it was a political decision, and politics and science don't always come up with the same answers.
We've seen a lot of that. How much of a problem do we anticipate the variants around the world? Yeah, how much of a problem are those going to be for us here in the United States? Do you think?
It's hard to say, because high rates of vaccination are going to change everything. The variants spread quite a bit more easily. You may have read about the outbreak in Elk Ridge Elementary, where we saw an attack rate higher than anything we'd seen before the variants appeared, and that outbreak was due to variants. And there are outbreaks among school-age and college-age kids throughout the country, demonstrating that the greater transmissibility of the variants does mean easier transmission. Working against that is vaccination. The vaccines that we have are quite effective against all of the variants. There's some decrease in immunogenicity, but we think that it's at a level where it should, in the areas where we only have lab data, we think that the decrease in immunogenicity is so small that it shouldn't affect efficacy. And for places where we have real world data, such as for the Pfizer vaccine in Israel against both the 117, previously known as the UK variant, and the 13.351, previously known as South African variant, the Pfizer vaccine continued to be very effective. Long-winded way of saying that the variants are going to make disease quite a bit worse among the unvaccinated and those who don't respond to vaccine. And, it is going to contribute to some breakthrough infections potentially among vaccinated people. So far, most breakthrough infections among vaccinated people are milder on average than they would have been without vaccination, which is terrific news. Efficacy against hospitalization is close to 100%, whereas efficacy against disease in real world studies is still in the range of 90 to 95% against symptomatic disease. Now, that said, we've seen a lot of evolution in just 15 months, and we can't predict the future. There aren't really great laboratory experiments to tell us just how much this virus could adapt and evolve. It's pretty scary how much it's evolved in 15 months.
Right. And across the country, we hear about variations in vaccine penetrance, and how much does that vary with regard particularly to kids, and how much of a problem is that for us within the States? Thinking about summer vacations and traveling around and that sort of thing.
Well, we haven't seen a lot of data yet about state uptake among teens and tweens, although this morning I read that so far 600,000 kids between 12 and 15 have been vaccinated just in the last week. So that's really good news, but it probably represents the vaccine enthusiastic, probably a lot of the kids of doctors, nurses, APPs, and not so much, folks without a medical background who aren't quite so enthusiastic. The variation state by state and even county by county is kind of enormous. And there are places in the country where you would be going into a highly vaccinated, pretty safe environment. I think that 70% of Vermonters have had at least one dose, and over half are fully vaccinated. And then if you contrast that with, let's say Idaho, where it's only, I haven't seen today's figures, but it's under 30% are fully vaccinated, and in the low 40s or perhaps only 40% have had one dose. For your under 12-year-old kids who are not vaccinated, a vacation in Vermont is safer and freer than a vacation in Idaho. I can tell I'm going to get hate mail from Idaho for that. I've lived in, both states, so.
And for think about this summer, particularly for teenagers, vaccinated and unvaccinated, how would you approach them differently? And particularly for, like going over to friends' houses, doing things perhaps with younger kids who aren't vaccinated or can't be vaccinated yet. How would you suggest we advise families how to manage that?
This is where I think the CDC guidance was, too simplistic. It doesn't really help you with the tough questions. I think that for vaccinated teenagers and their vaccinated friends, they can pretty much do anything that their parents want to allow them to do. And obviously, summertime for teenagers, the parents may have some other limits beyond COVID risk. We are so cautious about asking about vaccination status. If I were a parent of teenagers and my kids are old enough to have made all their decisions for themselves for a while now, I would find out about the vaccine status of their kids and encourage them to hang out and do whatever they wanted with their vaccinated friends, and have a different standard for what they do with their unvaccinated friends. Why? They're probably not going to get terribly sick by getting exposed to an unvaccinated person who carries COVID, but they could spread it. And that would mean you have to think about what your teenager who's been hanging out with a bunch of unvaccinated people who are not wearing masks is going to do. Are they going to volunteer in a nursing home? Are they going to visit their grandparents who have cancer? Those would be difficult situations. If they're just going to hang out with other 16-year-olds, then their shedding virus is less of an issue. So what about our unvaccinated younger kids? I think the basic premise is that outdoors is safe. Just, do what my mom used to do, kick us out of the door at 8 and open up the door at 6 p.m. for dinner and make sure we stayed outside all day long during summer. I'm being facetious, but I do think, although my mom did really do that when we were in the country, but I think that outdoor activities are safe for unvaccinated kids, and with very, very few exceptions of very crowded, tightly packed spaces, but indoors is a little bit more problematic. And I would really be thoughtful about what your younger kids do indoors. Can they go over to a friend's house where everyone but their other 8-year-old friend is vaccinated? Yeah, that's probably a reasonable thing to do. Should they be going to a group event indoors where people are singing and shouting and are unmasked and unvaccinated? I wouldn't do that. Everyone has their own tolerance for risk. Nothing is completely safe. We talk about, risky, safer, and safe. But a lot of activities you're going to have to judge as being probably less in the safer category than you would like your kids to do.
Any thoughts about where sleepovers would fall in that spectrum?
For fully vaccinated kids, sleepovers are great. Bring them on. That's one of the reasons to talk parents into getting their kids vaccinated. I think if you're talking about two friends who are unvaccinated and who are both not taking a whole lot of risky behaviors outside of it, I think it's a manageable risk that you should probably be willing to consider depending on your risk tolerance and the presence of high-risk people in your house and your plans for travel and things like that. But it's a tough one. It's an individual decision. If I were about to get on a plane and fly 3 hours to visit grandma who's 80 and on infliximab, I would not let my 10-year-old go to a sleepover. Whereas I might do that if we were staying in Utah the whole time and that was the one friend he was hanging out with indoors who was unvaccinated.
And what about the various vaccines, particularly think about the J&J vaccine? We know that that's been a risk for clotting rarely in adult females more. Are there variations in kind of risk of vaccines for kids?
Well, in terms of the mRNA vaccines, we don't know. And remember that the vaccine safety machinery, the juggernaut, is always churning. Every time you see an illness that may be associated with the vaccine, you can report it through VAERS. The rates of those side effects are compared to what occurs in unvaccinated kids. So we may learn something that we don't know about mRNA vaccines in kids right now. There are some investigations about possible cases of myocarditis, remembering that it's also May and it's Coxsackie season. So until we prove that they're actually associated, we don't know. So mRNA vaccines, which is what we're talking about for younger kids, no issues. The adenovirus vaccines are going to be a lot more interesting. The rate of clots is still very low, but where it happens significantly, all but 2 or 3 of the clots observed in the US have been in women of reproductive age, by definition, only down to 18, because that's as young as we've been giving the J&J vaccine. Will that extend to, post, menarchal girls down to 12 and 13? Probably. Will it extend in a different way to younger kids or prepubertal girls? I don't know. We obviously don't understand the basis for this gender difference, and it's probably hormonal difference. But I suspect that if and when J&J vaccine is licensed for younger teens, that we're going to have the same discussion that we do with young women, which is to say, this isn't a very common side effect, but you should be aware of it. There are other alternatives. They involve getting 2 shots. The J&J vaccine is safe and the benefits greatly outweigh the risk, but you should be aware that if you want to skip that risk, we've got another alternative for you. That's a long discussion to have every time you're talking about a shot for young women. So you might just choose to stock the Pfizer vaccine or the Mrna vaccine when it's licensed and give it to your teenage girls.
Yeah, that makes a lot of sense. And can you tell us about Utah's experience with multi-system inflammatory syndrome in children?
There was just an article today on the CDC data showing an undercount, and I checked with the state data, and the state data are actually way behind. So we've got a team at Primary Children's that has been caring for and actively investigating MIS-C, and it's headed by Nan Trong, who's one of the pediatric cardiologists, who's actually headed one in the big national study. So I got to give a shout out to all the other people who are doing this work. We've seen, as of today, we're either just above or just below 100 cases of MIS-C in kids. And these are, for the most part, pretty severe. The majority of the kids have ended up in the PICU for at least some period of time. The vast majority have had cardiac involvement. Some have had neurologic involvement. Some have had severe GI involvement. Most have done well with treatment. The hospital stays have been scary and sometimes prolonged, and the convalescence has taken some time. We know of 1 death for certain that was due to MIS-C because autopsy demonstrated that. There's another death that we believe was attributable to MIS-C. We've had 1 child need open heart surgery to remove an intraventricular clot. MIS-C is, it's the real deal. It's a serious illness. Now, I think that we've had about roughly 60,000 documented infections in kids under 18 in Utah. So the attack rate for MIS-C is pretty low. If it's 100 out of 60,000, you can do the math. That's pretty reassuring. But it's another reason, to when somebody tells you that COVID's not an issue for kids, to call bullshit.
Yeah, 1 out of 600 doesn't sound all that rare, actually. So, yeah, that's significant. And we know nationally there's been a preponderance of impact on people of color. Is that true in Utah also?
We're just doing the formal analyses of the relative risks, but just looking at the cases, it does appear that there are higher rates among Hispanic and Pacific Islander kids in our community.
But no other risk factors that we know of yet?
For MIS-C, none have been defined. There's a lot of interest in the possibility that they're genetic predisposing causes. And there's reason to think that might be true because the immune signature of the response to MIC, which is just beginning to be dissected, is pretty unusual. It doesn't look like bad COVID, and it doesn't look like a lot of other illnesses, which might suggest that certain genotypes predispose you to that kind of response, but we don't know yet. And we don't know why the children of color are at higher risk. It's really always hard to disentangle it from access to care issues and things like that. Because of course, in the US, genetics and skin color aren't all that related. We're all kind of mixtures, as been nicely demonstrated actually by work by Mike Bamshad when he was back here in Utah. We may look in the mirror and think we look pretty Scandinavian, but if we've been here since the beginning, our genes will probably tell us otherwise.
Right.
I'm first generation, so who knows what mine are.
Any other questions from the group?
I apologize if this has already been addressed. I had to step away for just a minute. Dr. Pavia, I'm just kind of curious about dosage of vaccine for kids versus adults. As a 225-pound male, the dose that I got, is that the same that a scrawny 12 or 13-year-old is going to get?
It is, and that's what they used in the trials. And they did not see any difference in side effects by age group. So, the trial was 12 to 15, since they had already done 16 and 17-year-olds. And the 12-year-olds who, by and large, were much smaller and had less muscle mass, did not have increased side effects. That's usually true with most vaccines, that we don't have to lower the dose till we get down to quite a bit younger children. And if you think about flu vaccine, we used to give 0.25 to kids. And then recently, most of the vaccine manufacturers demonstrated that 0.5 was equally safe. And so that's, of course, made everyone's life a lot easier in terms of what flu vaccine you buy in stock. My guess is we'll have to use a lower dose in the very youngest age cohort. We'll have to see with 6 to 12, they're going to do a dose ranging study. But I think 12-year-olds are just fine with this dose. And, you mentioned the 220-pound male. If you care for adults, you realize that there are a bunch of 70-pound adult women that you care for, particularly among the elderly. So the size range among adults is, a lot bigger than we sometimes think about. Which is, of course, why sometimes we need to get our adult colleagues to do weight-based dosing for some medicines. And it's kind of against their instinct, even though it's hard-baked for us.
Just one dose for all, really.
Yeah, I mean, a 70-pound or 75-pound elderly woman and a 380-pound morbidly obese man probably don't need the same dose for every medicine, but sometimes that's what they get.
1 amp, right? Other questions?
Can I ask y'all a question?
Sure, go for it.
So as you look at the idea of stocking vaccine, and I don't know exactly what kinds of practice settings you're all in, how many of you are already signed up and how many are going to do it? And if you aren't, what are the barriers to actually being able to do it in your practice setting?
That's a great question. Anybody care to respond?
I mean, I know that for regular childhood vaccines, the cost, having to buy it yourself and be at risk, is a huge barrier. Luckily, that one's been taken away.
We got one response that they're not signed up yet. They're waiting to learn about the storage and expiration issues.
Yeah.
And another responds that they have one office ready to go and they're working on their other offices. This is a group of groups practice. There are a lot of hoops to jump through, apparently. And another says they getting it next week, and have wondered if we bring it to a place of inherent trust, will we get more uptake?
Well, if you look, that's a great question. So if you look at polls among people who say they're thinking about or willing to consider vaccine, but haven't made a decision yet, one of the overwhelming responses is I want to do it at my doctor's office or my provider's office, and I want to talk to them about it. So I think having it in places of trust is going to be huge. But we also, I don't know that everyone realizes what a burden vaccinations are in practices, and we need to make sure that that's streamlined as much as possible. If the paperwork hoops are a lot, please give the state UDOH feedback on that. They seem to be pretty responsive to trying to reduce that. They have definitely made some accommodations so that if you're part of a group that can order drugs centrally and distribute, so if you distribute your drugs from a central pharmacy, initially you couldn't do that. It had to be used where it had to be delivered to where it was going to be used. They've changed that. So that's great if you're part of a big group, Intermountain or U Health. But even for a couple, multi-center practices, you may be able to order for all of your sites, store it centrally, and bring it out week by week as it gets used up.
And another practice says they're going to be giving it, and they're working on the storage issue. And another practice is rolling it out starting tomorrow. But they're going to start very small, and so they can get an idea of what kind of response will be, and get more staff trained.
Yeah.
And then a question: has messaging been shared about combining vaccines? I know I've read about something, but do you know how actively that information has been shared for practices about coordinating with other vaccines?
Well, probably not widely enough. This is the third group I've met with to share that information. The UDOH is sharing it, and it's on the CDC website, but there's so much information out there. I'm not sure that there's been a specific mailer or something that's really targeted to people who are on the fence. I do suspect that they're also waiting to get the final word on the 4-week refrigerator temp before they do some real education, because I think that may be a deal maker for a lot of people to know that you don't have to separate it from your HPV, your flu vaccine, your Tdap, and you can keep it in the fridge for a month. And that means you'll have to be a registered certified fridge, but if you're giving any other vaccines, the refrigerator that you're using for other vaccines, I would imagine would meet all those requirements.
Right. Okay. Anybody else have questions or input on how you're approaching this?
Well, you probably have all heard this, but maybe I should bust the most common myths that when you start talking about the vaccine with people that they're going to bring to you. Yes. So fertility, there is absolutely no evidence and there's no biological plausibility to the idea that there's an impact of any of these vaccines or COVID infection on fertility. There's some reporting in Reuters and the Wall Street Journal that both Russia and China have been actively spreading that on social media. So it's actually not just wrong, it's a maliciously spread bit of disinformation. The other big one is spread of vaccine. That one seems kind of ridiculous to us, but it actually is going around, and it seems to have targeted communities of color. The idea that vaccinated people could spread the vaccine to other people and make them sick and affect their ability to have children, which seems kind of far-fetched. But these days, the far-fetched often get real life on social media.
Well, if we can believe that they put microchips in there.
Yeah, right. In that these vaccines are not raised in cell culture. There was the use of cell culture to propagate the initial seed strains. and those cell culture lines were derived in the early 50s from fetal tissue, but no fetal tissue has been harvested, used, or otherwise involved in the production of these vaccines since those cell lines were created in the 50s. And if you have Catholics who are concerned about that, Pope Francis has said that these vaccines are okay to use, even though there have been, I think, 1 or 2 US cardinals who have said otherwise.
And another question, is it accurate to say that vaccine immunity is better protection than natural immunity, that is from the disease itself against the variants?
That seems to be accurate. And we have a couple ways of looking at that. One is reinfection. Reinfection is widespread in Brazil and now in South Africa among people who had natural infection in the early waves of the pandemic, and now are being reinfected with variants and sometimes with quite severe illness. The other is laboratory based. We have substantially 4 to 10-fold higher neutralizing antibody titers with the mRNA vaccines than with moderate to severe natural infection, and it can be quite a bit lower with mild and asymptomatic infection. It also appears to be broader immunity with certainly with the mRNA vaccines, so better activity against the variants. And in some ways, it's very preliminary data, but the best immunity so far actually seems to be when people who've been infected get vaccinated with mRNA vaccines. They seem to have very broad protection and very high levels. And this, in essence, they're getting, a prime with 2 boosts.
Right. And is there any data on reinfection rates for kids in Utah?
No, I don't believe we have any.
Okay.
I mean, we've seen individual cases that are clearly reinfection, but I don't believe we have any information about rates.
But if we don't have any additional questions, we'll let you go, Andy. We thank you very much. This has been very educational, and we really appreciate you taking the time to talk with us.
Well, thanks to all of you, because I think the burden of vaccination as well as caring for kids with COVID in the next couple of months is going to fall to you in primary care. And so anything I can do to make that easier and answer questions, I'm happy to do. But you're the people that your patients trust and are coming to, and I want you to have good information so they can get it from the source they trust the most. Thanks.
Great. Have a great day, Andy. Thanks.
Thank you so much. Wow, that was terrific. One more.
A lot of good information.
Yeah. Yeah. Fantastic, everyone. Still tough, still hurdles, but that was some very helpful and positive information, I think. So, all right. Does anybody else want to talk about anything that maybe we didn't get into enough, or you'd like to follow up on with the few minutes we have left about COVID? I know that there's the mask situation, and I certainly, Dr. Pavia can't tell us, how to address that, but it is really, I don't know, it's a really tough one to talk to our families about what to do in those cases. So, sorry about the dog.
Mindy, I just wish there was a way that we could do away with social media. I just think that all of this nonsense, like he was talking about, some of the things that Dr. Was talking about, I think it just stems from social media. And it's so disheartening that it comes from maybe like a group of 10 and it spreads so fast, so quickly, and just not factual at all. It's frustrating.
Yeah, it is. And And people have strong opinions on masks, and the advice from the CDC has not, in my opinion, helped that. What I've seen on social media has been confusing, and I just try and put my mask on and stay out of the fray. But yeah, we need to gently encourage the families we work with to do the safest thing. And it is really scary for these kids who are immunocompromised. You know, that's a hard thing to tell them, that because of people's willingness to believe things that aren't factually true, that they have to be even more careful for maybe forever. So. Well, it was terrific to see you all. I think this was an excellent meeting. I'm delighted with the numbers. We had a lot of people who were able to join us today and hear Dr. Pavia. And again, you know, it's always just great talking with you guys about what's happening in your jobs and your practices. Again, please feel free to use that listserv email. You can always just email me and then I'll send it out if that's easiest. Seems that's often what we do, and it works really well. So love to hear from you. And again, just great to see you. Take care.
Minnie, can I just ask really quickly? I would be interested in maybe a COVID update over the next couple of months from everybody as you have more experience with immunizing kids in your practice. I think sometimes, you know, anecdotes and stories of parent reactions or how it's working out, or adverse reactions or anything, might be informative for the rest of the group. So I don't know. I don't think it needs to be an every month sort of a thing, but I'd be interested in touching bases on that one in a future meeting.
I think that's a great idea, Eric. And again, guys, it may be an opportunity to use some of those motivational interviewing skills as you're talking with parents, right? Really listen and try and get at the heart of what the concern is there, and see if you can kind of meet them where they are. All right, well, you get 5 extra minutes. Have a wonderful rest of your Wednesday.
Thanks, everybody.
Take care, guys. Bye-bye.
Thank you.
Thank you.
Whoops. Leave the meeting.